Alrighty. They've been trying to help us, encourage us to start and end on time, so I'm going to go ahead and get started. Good morning. I'm Viet Nguyen. I'm a physician informaticist working on interoperability and FHIR. Hopefully some of you recognize faces from my other presentations. This is my second to last of 5 presentations at DevDays. I don't know how I signed up for this many, but it's been fabulous and fun, and the interactions have been great. So today we're going to talk about the Da Vinci Project, and I know there's been a lot of questions about it, and so my role is to help you kind of understand where we are, the purpose of it, and to give you a sense of where our trajectory is. So off the bat, because I'd like to know who's in the audience, how many developers do we have? All right. So I don't get into the code level. I always caveat that. I'm a physician informaticist. You get down to Java code and that, I can write it, but it's not going to be good code. But I can talk most of the things above that. How many folks are from payer organizations? Okay. How many folks are from provider organizations? Okay. And how many folks are well, I guess you're the developer, are vendors? Okay. Did I miss anybody? Research? Okay. Fair enough. All right. So I'm going to start off kind of at a high level because I think it helps for especially developer folks who understand the technology really well but may not be in the domain to kind of understand why we're doing things. So about 10 years ago, roughly, the Institute for Healthcare Improvement, IHI, developed this notion of the triple aim and what we need to do to improve healthcare. And that triple aim includes improving the patient's experience with the healthcare system, improving health population-wise, and reducing control costs. So keep that in mind as you're doing your work and the efforts we do, and I feel strongly that FHIR helps towards this aim, and I'm going to hopefully demonstrate to you why I think that way. And Da Vinci is also working towards this triple aim as well. So this diagram I use quite often to help folks understand what I see as the drivers, some of the drivers in healthcare. There are lots of drivers in healthcare. Healthcare is roughly 18% of GDP, which means it's huge. And so there is no one easy solution to healthcare, and so we're trying to focus on one part of it. But in my mind, healthcare drivers are patient outcomes, really should come first. How do we improve the care of the patient? But within that, we have regulation that affects what we do, and part in that is also the market and how our market systems are, and then we have cost constraints. And what value-based care does is bring those 3 together into the center. What today is a fairly small Venn diagram overlap, and hopefully will become a much larger Venn diagram overlap. And because it's small today, because the way healthcare payment is done is what we call fee-for-service. Who here knows what I mean when I say fee-for-service? Okay, for those who don't know what fee-for-service, it's essentially the notion that as a physician, I negotiate a price with a payer or a set of payers. Sometimes, usually by myself, I have little to no leverage on what that is. And I provide services for that payer's members and beneficiaries, and then I send in a bill, and if I do it timely and I have my documentation, I get paid. And we're moving towards the notion of value-based care, which is not just I get paid for what I do, but I get paid for providing high-quality care. And this transition is already in place. It's really has begun with the federal government with the Affordable Care Act. There's efforts to modify those activities, but we have things like this. You'll see MIPS down here, where and alternative payment models where providers are now being asked to accept kind of a bundled payment for a service. The first one was the total joint replacement. So a hospital will get one single bundle of payment for all these outpatient surgeries. So their incentive is to provide high quality care that's efficient, because if they have patients that stay longer, it costs them more. But if they get the patient out too early and the patient gets readmitted within 30 days, they get penalized. because the readmission isn't paid for, and they might get their payments for the original admission revoked. So we're trying to balance this quality and cost part. And so right now it's a very small percentage of your payments, and this is federal programs, are kind of this value-based care. But over time, they want to transition to more and more of it. So how do we do that? We do that by trying to control costs in several different areas. And this diagram was from Sagren Moodley, who's our chair of the Da Vinci. And we do that by avoiding admissions whenever possible, having patients avoid going to the ER if their condition can be cared for in other settings, using the right site of service. So the combination of a hospital when you need it, ER when you need it, but your office if you have an established care, or even these minute clinics. Managing prescriptions, managing the use of radiology and imaging, and managing specialty labs, especially now that we're having genomic tests. They can be very expensive. And then areas where we can improve in revenue is to control, to have more accurate diagnostic coding, doing quality incentives, and then maintaining a population and keeping them healthy. One of the challenges we have in healthcare is, and all of you working for organizations, is often your healthcare plan changes every year. But if we, through personal view of having the ACA and people having insurance and buying their own insurance, over time, if they stay with an insurer and a payer and a provider, there's a long-term incentive for managing care. Because how often do we change our car insurance? As much as they advertise, but we don't really change it that often, because if we're happy and we're getting good service and it's reasonable cost, we stay. And so there's an incentive there to have a longitudinal relationship. So the way we achieve this, in my mind, and for many, is through interoperability. We need to be able to have data flowing from payers to providers to secondary data users, research in a way that's always caveated by securely, safely, and with proper authorization. And so we created this diagram, and it's a feedback. This thing cut off somewhere. Last year at the Digital Quality Summit, we had a working group to try to think about how the data flows today. And so this was originally called the measures value chain, but I'm calling it the clinical data value chain. And what this really demonstrates is that there are kind of interfaces between how the data flows. The physician and a provider sees a patient, they're gathering information in the real world, but they're having to put it into a system, typically the EHR, that stores that information. That EHR, the data is then transferred to a data aggregator, whether it's a payer, whether it's a registry. There's quality and analysis done on that, curation done on that, and then those organizations, which may be the payers or the providers, then have to create some measure reports and send them to a measure reporting agency like HEDIS. And ideally, that you get a sense of how you're doing, but right now, a lot of these measures, how old do you think some of this information that you're getting measures on are? 6 months, a year. So how often is that really actionable? Not really, right? And so what we need to do is to get that measure information of how well an organization is doing back to the providers and those provider organizations in a way that where it's prompt and it's actionable, but it's also accurate, so that they can change behavior, they can affect patients' care. And in my mind, FHIR and its related technologies around SMART, CDS hooks, CQL, and CDS all play a part in that. Because if you envision, this first loop is you're just gathering information. You're just seeing how you're doing today and setting a baseline. Once you do that, you want to implement evidence-based interventions through CDS. And so things like there's applications out there around opioid prescriptions that are using a CDS hooks application, so when a prescriber prescribes an opiate, they get the guidelines. So that uses FHIR, it uses CDS, and it uses FHIR data. So you use FHIR data at the beginning, you store it or make it available and transfer as FHIR data, you do the analysis in FHIR data, you use it then to aggregate, and then it comes back, and it goes back and improves your CDS all through FHIR. So now it's that liquidity that we really want to have in the clinical data that we haven't really had as well before, because in today's world, the data gets transformed at every stage, and so it loses that its utility. Beginning with an effort with HL7 over the past couple of years in a group they call Partners in Interoperability. This partnership and group was formed to bring together payers, providers, and pharma to look for common use cases that we could use FHIR and interoperability to try to tackle. And the FHIR has been very active in the clinical space, and the EHR vendors and the efforts around Argonaut have really pushed the adoption of FHIR, and it's fabulous. The payers had been a little more cautious, understandably. They want to see that FHIR is really going to take hold, that it's going to be something that's really going to go forward. And I think talks during DevDays from Google and Apple and the demonstrations by the EHR vendors have really given them that level of confidence that this isn't a fly-by-night standard. And so from the efforts of the Partners in Interoperability, a couple of folks within HL7 started talking to the providers, led by Linnell James with the Blue Cross Blue Shield Association and Bob Dieterle. They started to talk to the payers and say, it's really time for you guys to jump in, because it's better to be part of the solution than to be told how the solution works. And so we formed a group called Da Vinci, and it was formed in around the time of HIMSS. And it includes 10 of the largest payers in the US, and if I named them, you'd recognize them, and I'm hesitant to name them mainly because we gotta ask for permission. So just know names that if I said them, you'd know them, of the 3 major EHR vendors. I know, I'm always trying to be PC about these kind of things. We have the major HIT vendors, and we're currently recruiting providers into this because all these solutions require everyone to be on the same page. And what we're doing here is that we want to bring them together to solve, identify value-based care use cases that FHIR can help solve. And so this diagram is to help folks understand, where does Da Vinci fit into the entire not the entire, but one aspect of the FHIR ecosystem. So on the left is Da Vinci. We're looking to solve value-based care and data exchange. We work with HL7. We are under the auspices of HL7, and our use cases are very focused on value-based care. We look to define the requirements, create implementation guides and reference implementations, and then pilot them. Versus another group that's very important that some of our members are also participating in, called the Payer Provider FHIR Task Force, the P2 Task Force, and that was formed under the auspices of ONC. And their task is, how do you scale these solutions? So how do you do identity management across an entire FHIR-enabled ecosystem? How do you have a provider directory that's a FHIR-based provider directory? How do you do discovery of endpoints? Because if you have one provider may have a dozen or more payers they have to communicate with, and payers have potentially thousands of providers they're going to have to deal with. And so how do they find those endpoints? How do you do things like identity management? How do you look at security and authentication? SMART is really great at the EHR, single patient, single provider level, but how do you scale that kind of authentication, authorization to organizations? And then how do you do testing and certification of these solutions at scale? So that helps you kind of understand our relationship, because in what we do in our use cases, we tend to scope out these issues around identity management and security to the P2 FHIR Task Force, because we don't want to create a standard or an implementation that isn't going to scale and isn't going to be adopted broadly. So the goal here is then to help payers and providers transition from this value-based care to more of what we do based on VBC, and less of what we do through fee-for-service. So Da Vinci was formed to then empower the provider teams to do essentially what I say is do the right thing both clinically and administratively at the point of care. So for those of you who are providers, you'll see the use cases. A lot of what we find out that we did wrong or didn't do enough, we find out after the fact, and it causes additional documentation burden and requires us to bring back the patient, and it delays care. And so that we want to develop solutions that can be part of a patient care workflow. We wanted them to try to do it right the first time and help them do it right the first time, as opposed to having to repeat the communications with the payers. We want to develop a single solution, and that's why we have the EHR vendors at the table and the providers and the payers at the table, because if we can have them agree that an approach for a use case makes sense and supports the workflow, the data requirements, and can be implementable within the EHR, whether it's implementable today, which is ideal, or can be part of a roadmap for their FHIR adoption over time, then we grease the skids on the information flow. Because if a provider organization only has to use one method to communicate with all of their payers, it's going to be a lot more efficient than having to build one point-to-point connections. And so really, FHIR has reached this level of maturity that the payers really want to come on board. They've written their checks and signed their agreements to do that. And so the approach we're using is multi-stakeholder. So we have all these, the major EHRs and the payers and providers. We are bringing on the best talent within these organizations, their subject matter experts, as well as FHIR expertise. We have Lloyd McKenzie and Eric Haas, FHIR leaders from the early days, helping us make sure that we're doing it the right way, because the clinical resources, if you look on the spec, are fairly mature, because the clinicians have been using it and you've been putting it into your systems, but the financial resources are a little bit less mature. So we want to make sure that we're building the standard in the best possible way at the beginning, recognizing that the standard will evolve and our usage and understanding will evolve over time as well. So we have participation both from contracted folks as well as in-kind folks from each of these organizations, and it's really been great. I mean, some of these calls I have 20 or 30 folks, and people are really engaged in trying to help us understand their workflows and their needs. So right now, these were the 9 initial use cases that were defined through the partners interoperability, looking at priorities. And so the first 2 that are in flight right now is 30-day medication reconciliation and coverage requirements discovery. Later today and tomorrow at a meeting down the street, we'll be kicking off document templates, coverage rules, and the eHealth record exchange. And I know these are short blurb terms, and you may have in your mind what you think they are, but part of the process is to go from what everyone thinks this should mean to what does this collective group think it means. For this, and what we're going to do now, I'll get to the first 2 use cases, but our goal is to create 2 things. One is a palatable implementation guide that will help other organizations implement what we have designed. We expect that the vast majority of what we're going to do is going to be balloted through HL7, because that's also the parent organization, and it's also a place where we can do quality checks. So of the 2 use cases, we have the Clinical Quality Initiative work group, and we have folks here from that, sponsoring one of these use cases, and the other is the financial management group. So we're going to use the HL7 process, but in order to be really agile, because HL7 is great, but Agile isn't necessarily one of its great strengths, is we want to do a whole bunch of things in advance and use the Da Vinci collaboration to build the implementation guides, keep the work groups informed, but do that work really rapidly, and then bring it to the work group for their quality check. And then we want to build a reference implementation. And reference implementation as a terminology term has a lot of different semantics for different folks, but what we're trying to do is to have an implementation that you could go to a site, see what a user interface for the payer and a provider would be, and be able to see what the transactions would look like, So just to demonstrate what's in the implementation guide. And what's been done in the implementation guide or will be done in the implementation guide will be open sourced code. So then when you go to do it, you can look and see how we did, use the code. So 30-day medication reconciliation. I've got 20 minutes. Okay. So this is a use case that I'm leading along with Linda Michelson, who's here as well. And the idea here from the clinical layer is that a patient of mine has been seen in the outpatient setting, and we have him on a steady state, or let's just say and a set of medications. We call that the outpatient medication list. At some point, the patient may get admitted to the hospital, and there's a task, a J-code task at admission. You do medication reconciliation, which means I need to know when I admit them to the hospital what their medications are. And during that hospital course, I may add medications, I may put some on hold, I may discontinue them, and then at discharge, I'm supposed to do another reconciliation that says, okay, these medications when you were an outpatient, I'm going to have you hold for now until you see your provider. Your IV antibiotics, I'm going to change to oral antibiotics, and I'm going to add something else. And then that list is created. Today, that list may be in paper. For a lot of places, it is just paper on a medication reconciliation form. It may be in the EHR, but it's not always consistent. It may be in a CCD, ideally. The idea then is that that patient, at the time of discharge and within the window of 30 days, is expected to be, that clinically should be seen by their outpatient provider, and a medication reconciliation is done. If I didn't take care of the patient in the inpatient, I would get that list, that inpatient discharge list, and I would say, oh, it looks like they added your antibiotic, and you have 10 more days. I need to add that to your outpatient list. So you want to essentially use those two lists to create the go-forward list, and that's kind of the act of reconciling medications. The challenge today, and the problem we want to solve is, the payers often know because they get ADT notices or calls from the utilization that their patient is in the hospital. They may or may not know that that patient gets discharged. Often they'll know. But they don't always get that medication list because it's on paper. And often, unless you're in the same system using the same EHR, the outpatient provider might not have that list. So what happens today is the payers will call up the hospital, ask for a copy of the discharge medication list, call the patient, do you have a copy of the medication list? Then call the provider, do you have a copy of the medication list? And ultimately get that list to the provider and say, can you reconcile this? And we're 20 days into it, you have 10 days to see this patient or to review this list. And so we want to shorten that time. And we want to be able to have the payer know that that medication was reconciled early enough that if they haven't seen anything, they can contact a provider. And so what we're doing, and I have a timeline of these events, is we want to focus with the end in mind, which is attestation. So we want the payer wants to know that the medication reconciliation task was done. And what we'll do then is work our way backwards, to getting the medication list in electronic form, getting ADTs in an automated way. But that takes time, and that's cross-use case needs. But with the attestation, the idea then is they see the patient, the major EHRs have a functionality to do medication reconciliation. They click that it's done and that they attest to it. And then in our use case and our FHIR requirements, we show that we collect the data, we bundle it up in a set of resources, and then we do a post on a payer server. At least that's how we envision the technical workflow. And then the payer has all the information they need regarding the patient, their IDs, their practitioner, the location, that they can at least know that it's been attested to and that they could find the information that they need to do an audit later. So I'll pause just a second. Any questions about that? Oh. Sorry. So the value here may be a little bit more to the payer, because ultimately the payers will have to report this to HEDIS. And the better that they can, they have the denominator, but the better they can improve that numerator, the better it is for them. But over time, we want to support the clinical by having, you can envision that if you're going to be a provider and you're contracting with a given payer, medication reconciliation may be one of the criteria that you have to follow and base your reimbursement on. So this other use case is called coverage requirements discovery. And for those non-clinicians, the use case, a simple use case may be I see a patient in the hospital, not in the hospital, in my office who has a new headache. And I evaluate the patient. I go, you know, I'm a little worried. This is a little unusual. I want to get some imaging studies on you. And I want to, let's go straight to MRI, whether or not that's part of the guideline. Just say, I want to go straight to an MRI. But often, if you're astute, you'll say, that's really expensive. Does your insurance cover it? The patient pretty surely doesn't know sitting in front of you. So we often will do one of a few things. One, we say, let's have you, when we're all done, we'll have you talk to the medical assistant, they'll call the insurance, and they'll see what we need to do. That's actually pretty good. Otherwise, I might just write an order. It says, head MRI for suspected suspicious headache, rule out anomalies, bleeding, mass. I hand it to the patient. They'll take it to a radiology place, and the radiology place, hopefully it was on their plan, and the radiology will try to get a prior authorization. And if they get it, great. If they don't, they might say, oh, Dr. Nguyen, you didn't gather this information in advance. You got to see the patient again, or you got to send more information. So this is this administrative documentation burden that we talk about all the time. So the idea here in coverage requirements is not specifically around prior authorization. It's asking the question, if I know the patient, I know in general what I want to do, whether it's a referral, a study. We do this in medications already, in prior authorization for medications. Do I need to fill out any forms? Do I have to gather any information in anticipation of doing a prior authorization? And so what the idea then is that we can send information, whether it may contain PHI for the commercial payers, or it may not contain PHI because Medicare doesn't have specific subplans. We send the information about the patient and the procedure requested and any potential clinical information to support that. And then we get a response from the payer. And that response may be as simple as, yes, you're going to need a prior auth. No, you don't need a prior auth, which is easy. Yes, you need a prior auth, and here's a website to the beneficiary documentation, your coverage information, because maybe that payer doesn't have computable rules, and they always have a human kind of answering that question. If they do have computable rules, they might send you to a web page that says, here is the form that needs to be filled out. An example for Medicare is if I want to order oxygen, I have to have a form documented that says that what the patient's condition is, what their oxygen status is, and I have to have it in my record. So I could provide that form. They could provide me a link to that form. Even better, I could get information back around a computable form that I can just fill out or have a medical assistant or someone fill out. But the idea then is that I've captured the information I think, and the payer thinks, that I need to have captured in order to substantiate a prior auth later on. It's not a perfect approach because it's not perfect prior authorization, but it helps reduce that data and documentation burden. Any questions on that? Yes, sir.
Kind of more of a general question.
Sure.
Is each of these use cases a separate IG, or are you going to combine into an Uber one? And then how much overlap will there be with US Core? I imagine resources,
Sure.
there will be some.
Sure. So the question is one Uber IG or multiple? And it would be multiple IGs. And the other question around US Core, philosophically, we're trying to use US Core as much as possible, recognizing that it's pervasive in its implementation, and it has a group that curates that as well. Fair? Other question? Yes.
Just a comment. So I know on the EDI side, I used to work for a clearinghouse. We had the payers rules sort of encoded so that we could room claims before we sent them over and be able to give advice before we sent them. Are you talking to any clearinghouse organizations in terms of being able to move them out in and help solve the sort of point problem?
Sure. So currently we do not have EDIs and clearinghouses in the group because we're trying to focus on recruiting more providers. We recognize that architecturally there might be different methods of doing this. And so what we do have, and we're fairly confident, is that we have the X12 expertise from payers and providers to provide, at least get to the point where we know what data needs to be sent and received. So I don't know if that quite answers your question. I think ultimately the role of integration engines, of HIEs, and of clearinghouses will become clearer as some of these use cases develop. Other questions? 10 minutes, okay. Oh, I'm out of questions. Other questions. So keep in mind, I have another session coming up right after the break, and we're going to go into some of the things we're using on the technical level and talk a little bit more about the processes that we're using. So, question?
Yeah, so you've got a collaboration, multiple partners from multiple sectors, right? So I'm curious about your governance approach, decision-making,
Sure.
conflict resolution. Is there
Yep.
formality to that?
Yep.
Can you
Yes,
elaborate?
very much. So, we are convened under HL7 as the convening body for antitrust issues because we have competitors working together. So that's one layer. We have a steering committee, and that makes kind of the big decisions around budget and budget priorities. And then we have an operating committee that does the week-to-week, how are things going, we need more resources from your organizations and such. And we actually have a set of governance and operating guidelines that lay out how we work with HL7, how do we resolve conflict.
And that you developed, or did you inherit those?
It was developed and then approved by the members, the steering committee members. Yeah. And so keep in mind, again, that we're going to take our implementation guides and ballot them through the HL7 process. So for the standards process, we have HL7 for that. So we do the whole PSS approach. Yes, sir.
What's your process for recruiting members joining the
So at this time, we've paused outward recruiting, active recruiting, except for looking for more provider members. And the reason this is a little challenging is that in order to have a successful pilot, you kind of have to have a payer in a region. You need a provider that has a significant amount of patients for that provider, covered members. And ideally, that provider organization has some FHIR expertise and a good relationship with their EHR. So that narrows it down a fair amount. And each of these organizations have to have the bandwidth to be working on this. And I know all of us have to deal with that. And how much bandwidth do we have to add more FHIR capability? And so we're looking for those provider organizations that fit those first two criteria and have FHIR expertise, which also limits the number of organizations. Because although I'm a great proponent of what we've been able to do, Apple's success in the iPhone, that doesn't necessarily translate that each of those organizations has internal FHIR expertise that can create new implement new FHIR APIs without a good relationship and support from the EHR vendor. Other questions? Yes?
I was wondering if you've been partnering with any organizations that maybe don't quite have a lot of FHIR certs or using like traditional REST APIs or relational databases that are storing their data, but they're just starting to get onto the FHIR standard.
Most of the organizations that we have involved have teams within them that are actively working on FHIR or have done demonstrations of FHIR already. And so we know there's some education that we do with anything around FHIR, but we expect that they already have that commitment, and they've already demonstrated it by their participation in the FHIR community. And having APIs is great, but if they're not FHIR APIs, then we start going down the road of proprietary, and we're really avoiding proprietary APIs because everything needs to be open sourced. Yes. Oh, actually, what?
Sorry, back to 278 again. So referrals and all.
Mm-hmm.
So you're talking about having a provider say, okay, well, I think this might possibly need a referral. How do I find out what I need?
Mm-hmm.
That seems like a great step. But what about, have you talked about automatically integrating, like, okay, I need this thing in order to get the referral,
Mm-hmm.
and then get it, and instantly the referral is like fired off, or maybe even a connection where
Thank you.
you can just apply for the referral to it.
I think that would be great to put in the vision. We are being very mindful that there are X12 and other organizations that tends to be their purview and strongly rooted in regulation. And so we're in the space of kind of the innovation. Where can we work and then demonstrate the utility of this, and then bring in, convince people by our success that this is the wave of the future, and how we do it in the future. And I've actually had folks within Wheaties say that there's opportunities to combine the two. They don't have to be separate. But for now, we want to focus in that FHIR space and to manage scope, because we all know about scope. So, your question.
Yeah, my question was a follow-up of your governance process
Mm-hmm.
or your reconciliation process with US Core.
Mm-hmm.
If you run into a collision, what is the plan for back and forth between the two?
So I'm going to abstract that question a little bit to an issue around version, because I think it does come down to version. So US Core is in STU3, and the understanding is that they're going to wait till R4 is completed and valid, and then do a gap analysis and do updates to US Core and do an implementation guide for R4. And so each of these implementation guides we do will actually be two. One that is in STU3, because we know a lot of vendors are actually starting to implement things around STU3. And then we will work within the balloting process and tracking HL7 and the R4 ballot, and watching what the changes that may affect the US Core profiles, and try to anticipate. So we're fortunate that Eric Haas is here, and he works closely with Argonaut, and ultimately they're going to care about those same gaps. And so if we can work with them, keep them informed, and anticipate those gaps, then we can build them initially as Da Vinci profiles on US Core version 3, and then they'll harmonize with what US Core will do. But ultimately, we will have a placeholder and say we're going to adopt US Core.
And I think that the premise being that if at all possible, we will start with US Core.
Yes.
And we won't if they say something's required, we will
Yeah.
not say, oh, no,
Yeah,
it's
yeah.
required.
Right.
Just like,
Right.
and start over. And we may need to extend or possibly constrain.
Yes, yes. So for those who've done the profiling, we can do profile on profiles, but adding new profiles adds complexity in implementation. So we're going to try to minimize that unless we think it's absolutely necessary. A couple more minutes left. All right, let you out to go to your next session. If you're going to hang out here, great. We'll talk about some of the technical aspects of it. Thank you.